So the first case is a 68-year-old female who's found unconscious in a motor vehicle crash. So when we look at the history, she's a right rear passenger. Let's see, T-bone MVC. Let's see, the impact is on her side. Impact on patient's side. Let's see, the spidering of the window. So that indicates that her head hit the window probably. She was extricated by a first responder prior to arrival. Package on long spine board and C-collar, so she's immobilized. Alrighty, let's see. Other passengers indicate she struck the window and then lost consciousness. So struck and then lost consciousness. I'm just going to put down LOC. To be a little shorter there. So on exam, she moans, withdraws, intestinal rub, snoring respirations, and gurgling. Both not that good signs there. Lung sounds are clear. Equal chest excursion. Move this up a little bit. Abdomen is distended. And it's firm. And she moans when you palpate the abdomen. The extremities are cold with delayed refill. Vital signs: blood pressure is 88/40, pulse is 62, respirations are 20, room air sat is 88%, so pretty low. So, what other assessments are indicated? Well, if a point-of-care ultrasound was available, her shock state can be delineated. She's breathing a little bit fast. The pulse is kind of at a normal level, maybe slightly on the bradycardic side. Now, maybe this is an elderly woman or an older woman. She might be on a beta blocker or calcium channel blocker that's affecting that, but she definitely has hypotension. She hit her head, and again, remember, in a head injury, someone who's hypotensive, they've got to bleed elsewhere. So the point-of-care ultrasound might be able to help us differentiate where that bleed is, or where the shock is coming from. So what's the differential? Well, we have a head injury, and I would be concerned about an epidural or subdural hematoma. So that's one. Where do we think the bleeding is coming from? Chest or abdomen? There's no extremity injury, so we can take that off the list. There's no scalpel soft tissue injury, so we can take that off the list. So it's either in the belly or in the chest. Based on the signs and symptoms, she probably has an abdominal hemorrhage, given that she has a firm, tender, distended abdomen. The chest, she does not have, she is a little hypoxic, but she's got equal chest excursion and her lungs are clear. So this hypoxemia may be from another source. We'll address that in a second. So what's the treatment priorities for this patient? High flow oxygen to address her hypoxemia, IV fluid resuscitation with permissive hypotension. You know, her blood pressure is 88/40, so we may not need a whole lot of IV fluids. Depending upon your area, there may be some different feelings as to how much, but even doing a 250 ml LR or normal saline bolus and then reassessment would be indicated. This patient is hypotensive, so I would think about TXA as well. She has a bleed in a non-compressible site, so the TXA may help stabilize the clot and address her bleeding. What are we reevaluating? Vitals, SaO2. We can use our end-tidal CO2. We didn't mention that above in assessments, but we can use our end-tidal CO2 as a marker for perfusion. So that's another instrument that we have available. And the beauty of ultrasound is we can repeat it. It's non-invasive, doesn't expose the patient to radiation, and that's something that we can do to see if there is additional bleeding. And then finally, what's the appropriate disposition? This patient needs to go to a trauma center. So they need to go to probably the closest trauma center. Now, you could argue that with the head injury and the likelihood of the head injury being something significant and operative, that you may need to bypass to go to a level 1 trauma center. That's going to be at paramedics' discretion and how the system is built up, the distance between trauma centers, and that's something that's more in local practice that may vary from region to region.